Yeah. Hello, friends. So I'll be just giving a journal review in last 1 year uh, from non-European and non-US nations. So this talk was asked to be given in Ahmedabad on 13th July. That was on Sunday. So honestly, this was not an easy topic to prepare because if you eliminate any landmark studies from either US or Europe, you don't get too many. So I had to really scout through and try to see what best could be got. So I'll just take you through 6 to 7 articles that I felt were important, and we'll see how best this could be adopted to our clinical practice. So this was the first study that came from South Korea, which came in 2024 because I had to restrict to last 1 year. So this is effect of rigorous fluid management using monitoring of extracellular water ratio by bioelectrical impedance in critically ill post-operative patients. Prospective single-blind randomized controlled trial. So this came from South Korea in 2024. So in this particular study, what they did is they used bioimpedance assay to estimate the fluid balance in the body by looking at the ratio of extracellular water divided by total body water ratio and maintain the patients in a euvolemic state. So here the inclusion criteria was they took the patients who were post-surgical patients, and they optimized the volume in these post-surgical patients with fluid boluses and with diuretics, and euvolemia was maintained looking at the extracellular water ratio and total body water ratio. So this ECW and total body water ratio was meant to be maintained between 0.390 to 0.406, which was considered as a euvolemic state. So either they were not volume overloaded or they were not very dry if they were maintained in this particular range. And they had to use diuretics if it exceeded, or they used volume if it was less than 0.390 was the inclusion criteria. So the primary outcome of the study was the hospital mortality, and the secondary outcome was to look at post-surgical comorbidities and post-surgical sort of a progression of these cases and 28-day mortality. So when you look at the study, although this was a positive study, although I've said it's a negative study, because the primary outcome they looked was what was hospital mortality, but it did show benefit with 28-day mortality. So they had 167 patients, where 77 patients were fluid optimization was done by bioimpedance assay, and 90 patients were in control group. And when you look at hospital mortality, it was zero, where bioimpedance assay was used, and it was 4.4% in control group, and it did not attain statistical significance. But when they looked at 28-day mortality, the mortality was significantly less in bioimpedance assay as compared to the control group, and that was statistically significant. And when they looked at the post-surgical complications, so the overhydration, when they looked at the overhydration bit in the post-surgical patients, where extracellular water by total body water was more than 0.406, was more in the control group. And the capillary leak index was also more in the control group as opposed to bioimpedance, which only tells you that post-surgically, by using bioimpedance assay, they could avoid overhydration and they could avoid capillary leak sort of an index. So the conclusions from this study was targeted fluid resuscitation using bioimpedance assay by looking at this ratio of extracellular water by total body water. Although the primary outcome was to show reduction in hospital mortality, it did show benefit in reducing 28-day mortality and post-surgical comorbidities or post-surgical morbidity. Let us use the word post-surgical morbidity with overhydration or with extravascular or capillary leak index was found to be less. So this was a sort of a positive study where it shows some promise with the use of bioimpedance for fluid optimization. So then the next two trials, which are the follow-up trials, was the team study. So although the year it says is 2022, I had to give this as a backdrop because what I'm going to discuss is the follow-through study from this data set that they did in 2024. So it is called the team study, where they looked at early active mobilization during mechanical ventilation in the ICU patients, where even patients who are mechanically ventilated, they did early mobilization to see if it does have any impact on the outcome. So this came is in NEJM. Here they took 750 mechanically ventilated patients and 371 were randomized to early mobilization and 370 was randomized to usual care. And the primary outcome, they looked at patients who went out of the hospital alive and were alive at the end of their therapy. And they found that there was no difference. So the whole hypothesis was early immobilization should improve the outcome. So the patients going out of hospital alive and surviving was no different between early mobilization and usual care. They looked at 180-day mortality between early mobilization and usual mobilization. There was no significant difference between early mobilization and usual care. But what they found was patients who were early mobilized had increased adverse events. So as you see, the adverse events was 9.2% as compared to the usual care, and that was statistically significant, which highlights that patients who are mechanically ventilated, if you do early mobilization, it could increase their adverse events. They looked at quality of life, disability, cognitive and psychological functions. They were similar between early mobilization and usual care. So the conclusions they made out of this study was the high intensity early active mobilization did not lead to patients going out of ICU alive or out of hospital alive is what was shown. Although it is 2022, the follow-up of this particular, and it increased the adverse events. The follow-up of this came in 2024. And if you look at the adverse events which were reported to be high in early mobilization, blood pressure, altered blood pressure, cardiac arrhythmias, and desaturation appeared to be the commoner side effects that tended to happen in patients who are early mobilized and who are on ventilator. So, and the follow through of this study came in 2024 in American Journal of Respiratory Critical Care. It's a follow up of the same patients. Impact of high dose early mobilization on outcome for patients with diabetes. So, which means here they took the diabetic patients from that team trial and they tried to see in diabetic patients whether early mobilization has had any benefit. So the background is 20% of the ICU admissions constitute diabetic patients and they respond differently to early mobilization of the hypothesis. So the primary outcome was to look at patients who went out alive and out of hospital at day 180 was looked at the primary outcome, and secondary outcome was to look at 180-day mortality and 180-day functional. This is only diabetic patients, functional outcome. And they had the same team trial, the same number of patients. It was a data they took from that and they analyzed diabetic patients. So 371 were diabetics and 370 were non-diabetics. And if you see patients who went out alive and out of hospital at the end of 180 days was more in non-diabetics. So which means diabetics had sort of higher mortality and they did not go out of hospital alive at 180 days. That's what it says. So basically, diabetics didn't do well as compared to non-diabetics, but and 180-day mortality, as you see, was more in diabetes, 30% as opposed to non-diabetes. That was significant. This is overall diabetes. Then they substratified in diabetic patients who were early mobilized, high intensity early mobilization compared to non-diabetes who did not undergo high intensity early mobilization. And if you see, there was no difference between diabetics and non-diabetics with regards to patients who went out of hospital alive after early active mobilization. But when they looked at 180-day mortality, they found that the mortality was higher in diabetic patients who were mobilized early. So this is a very strong sort of a finding that came out. So in diabetic patients who were mobilized early, the 180-day mortality was found to be higher. So the conclusions of this particular trial is high intensity early active mobilization in diabetics did not reduce the patients becoming alive or survive at 180 days. But what it showed is it increased 180-day mortality in diabetics. So this NEJM study and the follow-through of this team trial, which came in AJRCC, sort of tempers down our enthusiasm of early mobilization because it did not show any benefit. Adverse events were more in the first team study, but if you take diabetics, they may tend to have higher mortality if you do early active mobilization in a high intensity way is what was showcased. So this is something that we can keep in mind that we don't have to be sort of over pedaling or overemphasizing on early active, high intensity mobilization in diabetic patients. So that was about that particular trial. Then this particular trial came in JAMA, which is the HAPPEN randomized controlled trial. So effect of high intensity versus low intensity non-invasive positive pressure ventilation on the need for endotracheal intubation in patients with an acute exacerbation of COPD. So this was also a very sort of a good sort of a trial. And this we often see in ICU where if you're not optimizing NIV parameters well, you would often see that they end up getting intubated. So this particular happened randomized control trial emphasizes on the need for optimizing your inspiratory positive airway pressure to generate good tidal volume so that you can prevent intubations. So they took COPD patients with high CO2 as the patients in this particular group, and they compared high intensity positive pressure ventilation versus low intensity positive pressure ventilation. And they showed whether there was any difference in reducing the need for intubation when you provide high intensity positive pressure ventilation. So this study was done in 30 ICUs from Jan 2019 to 31st Jan 2022 in patients with COPD with CO2 more than 45 millimeter mercury who were on 6 hours of low intensity positive pressure ventilation and in non-invasive positive pressure ventilation. Intervention 1:1 randomization. So in the group which got high intensity non-invasive pressure ventilation, IPAP was increased until your tidal volume could attain 10 to 15 ml per kg versus compared to low intensity NIV is where IPAP was increased to attain 6 to 10 ml per kg of tidal volume. So obviously this is quite intuitive. When you use high IPAPs, you generate high tidal volumes and that may help you to reduce your CO2. So this is what they checked. So very useful, and they had 147 patients in high intensity NIV and 153 patients in low intensity NIV. And the low intensity NIV were allowed to cross over to high intensity NIV if they were failing to generate good tidal volume and if they were deteriorating. So there was a possibility of them to cross over. So when you look at the results, mean age was 73 years, 68% were males. They had 300 patients, 147 were in high intensity NIV and 153 were in low intensity. If you see the intubation rates was significantly less in patients which got high intensity in NIV, which is quite archaic and intuitive for intensivists because you have to optimize your IPAP to generate good tidal volumes to reduce CO2 so that you prevent intubation. That was showcased in this article happen where intubation rates significantly lessened where high intensity NIV was used. Within the group, within high intensity and low intensity, the risk of intubation was 3.4 and 3 point. That was not significant. Of course, the abdominal distension was found to be higher in high intensity, where higher IPAPs were given to generate 10 to 14 ml per kg of tidal volume. So the conclusions they made in this particular happened randomized control trial was high intensity NIV definitely reduces the risk of intubation is what was shown. So that's about that particular study. Then we'll look into this particular study, which came in 2024 from China, where they looked at continuous glucose monitoring versus conventional glucose monitoring randomized control trial, where they compared continuous glucose monitoring in ICU versus point of care monitoring of blood sugar levels. And primary endpoint was 28-day mortality. It's a small study, 96 patients, 48 patients were in continuous glucose monitoring and 48 were in point of care. And if you look at 28-day mortality, there was no difference. But the mean glucose and the time-weighted average glucose was significantly better in continuous glucose monitoring. That was significant. So the conclusions they made from this randomized control trial was when you compare continuous glucose and point of care, although it did not reduce 28-day mortality, it improved glycemic control was what was shown in this particular study. So akin to this study, Indians, so because I had to cover one article at least from India, so Indians have done one study, which was a retrospective study, which came from Maharashtra, continuous glucose monitoring in patients with diabetes, single center study in ICU. It was a retrospective study. Here they looked at in patients with, it was retrospective, in patients who were monitored with continuous glucose monitoring, the median percentage time where blood sugar was found to be in the range was 59%, means they could maintain good glucose control within the range that they had determined in 59%. Below range, which is hypoglycemia, was 2%, and above range was 36%. And here they compared with pre-admission HbA1c. So pre-admission HbA1c was 8.8%, and the projected sort of HbA1c after they put them on continuous glucose monitoring was 7%. and median blood sugar level pre-admission was 246. And in patients who are on continuous glucose monitoring, they could maintain less than 180 at 167 milligram. So, which means continuous glucose monitoring definitely has a role in maintaining good glycemic control, but whether it has any bearing on the outcome, that is something we do not know. So this is, I think, very important. Of all the studies, I would pay attention to this particular study, which is important for the future generation of intensive care, more so in India, as to trained intensivist coverage and survival in critically ill patients. It was a nationwide cohort study in South Korea. So it's a very important study. So I would like to emphasize, when I came back from Australia in around 16 years back, there were hardly any trained intensivists in India. At least in Bangalore, there were none who had gone through structured training program with a qualification, and came with an intent that we set up a closed system ICU or intensivist-led ICU. And now you have so many intensivists coming out, but it saddens me that 16 years, there are not many ICUs which are purely running on that model as an intensivist-led, as a closed ICU. So that is little saddening, because our trainees have not really been successful in championing the cause of closed ICU, which has been elucidated in this particular trial, which is very important, and pay attention to this particular trial. So what is the evidence? The evidence is intensivist-led ICU has shown to improve outcome. There are multiple studies. So there was this study that got published in South Korea, published in AJRCC 2007. Then this was a study which came in chest in 2009. This was another study which came in 2013 from Canadian group, and this was another one from Chinese. All these studies, all these four studies from 2007 to 19 have shown that the intensivist-led ICU in a closed system or in a closed ICU did reduce mortality. You have enough and more evidence to say. And there was this huge meta-analysis of 90 studies, 44,042 patients, compared closed ICU with open ICU, and they said closed ICU was superior in reducing the mortality ICU and hospital and reducing the ICU length of stay. You don't need better data than this. And it saddens me today that there are not many closed ICU or intensivist-led ICU. There are people coming out qualified, but they're unable to make it into some sort of a closed system where all the decisions are driven through intensivist, which is why this study becomes important, because Koreans have taken that stand, and I'll tell you how beautifully they did this study. And this was another study from Singapore, retrospective cohort study, where they found that intensivist-led ICU improves clinical outcome even in ECMO patients, and this was published in 2020. And of course, all this happens with improvement in training of the nurses and putting quality SOPs or quality sort of a systems in place in a hospital. This has to be adjuncted with that. And of course, the number of intensivists that should be there for the number of beds is something that one needs to determine, which influences the outcome. So this is the backdrop of this. So how did South Koreans did this study, and why did they do? Because it was a nationwide registry data. They did from 2016 to 2019. Look at the number of patients. So they have taken all ICUs in South Korea, and they've taken all their admissions, 1,14,000, or not 1 million. So it's 11 lakhs 47,493 admissions in ICU they took during that period. And they stratified between the units which were led by intensivists in a closed ICU. 44 lakhs 84,000 patients were managed by intensivist-led ICU in a closed ICU, and 6 lakhs 63,489 patients were managed by a non-intensive care trained personnel or in an open ICU. And look at the hospital mortality, 22% lower in intensivist-led ICU, in a closed ICU. And 1 year mortality was 15% lower with hazard ratio of 0.85. You can look at the confidence interval. All this was statistically significant. And this is what the studies have shown, that intensivist-led ICU significantly reduces the mortality, improves the outcome. And this hospital mortality was lower irrespective of the age of the patients, or irrespective of Charlson's comorbidity index, irrespective of whether it is surgical or non-surgical, because it's become a fashion now. Liver doctors want to have a liver ICU, CTVS doctors want to have a CTVS ICU, and some other neurosurgeons want to have a neuro ICU. But these studies, all the studies have shown it has to be managed by ICU team, because even in surgical patients, intensivist-led ICU has shown to reduce mortality. You don't need a better data than this for the future intensivists to shape closed ICU system, which is very unfortunate. It's not happening in India. And even for all the invasive procedures or treatment where invasive procedures are involved, intensivist-led ICU had ability to reduce your hospital mortality. You don't need better data than this. And this is the data which shows across all age groups, across all Charlson's comorbidity index, surgery or non-surgery. Intensivist-led ICU had a lower mortality, and intensivist-led ICU had lower mortality in patients who are on ventilator, who are on CRRT, who are on ECMO. You don't need better data than this. 1 million patients, you can't get a better data than this. And we have to applaud South Koreans for having done this data to showcase how intensivist-led ICU improves outcomes despite all the previous evidence that we have. I'll do a separate video on closed versus open ICU. And the conclusions they made was the intensivist-led ICU plus closed ICU design reduced hospital mortality and reduced 1 year mortality irrespective of age, Charlson comorbidity. So, and very interestingly, you read the full text of this article, this became a national policy and a national law that it has to run in a closed format, and intensivists who were working in a closed ICU and who were trained were given special incentives for running it as a closed ICU. I think this is the message. We're all healthcare leaders. It's very saddening. I heard one of my colleagues saying he went and met the owner of a chain of hospitals or a director who said he doesn't believe in closed ICU system. It is so saddening and unfortunate. It's shame to India that people are talking that they wouldn't. And this is a person who runs chain of hospitals, and he says he doesn't believe in closed ICU. So it can't get more shameful than this. Sorry to use this language, but this is. So I want our future intensivists to shape intensivist-led ICU and closed ICU. And this is the dream that we all came back from overseas and putting all the training programs here. So that's about it. So now we look into this particular study, a pilot multi-center randomized controlled trial on individualized sort of a targets, blood pressure targets versus standard care. So this came from Australian group in 2025 in Journal of Intensive Care, where they targeted blood pressure to pre-illness mean arterial pressure, which is called individualized blood pressure group, and to the standard mean arterial pressure, which is 65. It was a prospective open label parallel pilot randomized control trial. Primary endpoint was to look at the time weighted MAP deficit that happened between these two groups and percentage of the time duration where more than 20% of MAP deficit was found in these patients between individualized, where individualized means they took the pre-illness blood pressure as a reference, as a target versus standard MAP, and they looked at major adverse kidney events, and they looked at all-cause mortality at day 14 and all-cause mortality at 90 days, and they looked at cardiovascular adverse events less than 28 days. So when they looked at very small study, 37 patients, so the pre-illness MAP was maintained in 11 patients, 17 patients, and standard MAP of 65 was maintained 20. So time-weighted MAP deficit was less. So when they targeted pre-illness sort of a MAP, time-weighted MAP deficit was less, 7% as compared to 18%. And percentage of time duration, more than 20% of the MAP deficit was less, 8% as opposed to 53, which means the MAP deficit was less in patients who were calibrated to pre-illness sort of a mean arterial pressure. And they looked at all the secondary events, major adverse kidney events, there was no difference. 14-day mortality, there was no difference. 90-day mortality, there was no difference. And cardiovascular endpoint, there was no difference. Basically, what it tells you is it is important to take a reference of pre-illness MAP as a reference to target the MAP than the standard one number of 65 is what they have shown in this particular study. Conclusions is pre-illness MAP to be individualized is feasible with no adverse events. And these are the graphs which shows that the individualized blood pressure group had a ability to maintain better blood pressure targets without deficits. And if you take the percentage of time where more than 20% MAP deficit, it was found more in the standard group where they put a static number of 65 as compared to the individualized or a precision-based or patient-specific MAP, the deficit was much lesser. So summing up, friends, so those were all the interesting studies that I could get. So the first study was, again, just to recall your memory, the bioimpedance-based sort of a fluid resuscitation tends to reduce 28-day mortality, although it failed to show a reduction in hospital mortality. And the team trial basically showed high intensity early active mobilization not necessarily will get patients better and alive. It increased the adverse events. In diabetic patients, it increased the 180-day mortality was shown without any benefit. So you can temper down your ability to, or not your ability, your intent uh, to actively mobilize with high intensity of the diabetic patients. And the happened randomized trial, which came from China, shows high intensity non-invasive pressure ventilation definitely reduces the risk of intubation, and that is something that one should be calibrating. And continuous glucose monitoring system is something that is coming in out. So one could adopt this to maintain good glycemic control, but not necessarily it change the outcome in reducing 28-day mortality. And of course, this closed ICU system with intensivist-led ICU is the sort of a noise that I need to create here, that one has to move towards intensivist-led ICU and a closed ICU design. If your intent is to reduce mortality and 1 year mortality, and this cuts across all specialties, there's nothing like surgery, neurosurgery, liver, and saddens to say hospital owners who are setting up big chain of hospitals saying they don't believe in closed ICU. I would dissuade people going and working in such ICUs if that is the sort of a notion that people have. And the pre-illness map is something that could be individualized, which is feasible without adverse events. So these are the sort of articles which I thought were pertinent and relevant to the future of intensive care in India. So thank you, friends. Request you all to submit your valuable work to Journal of Acute Care. Of course, you can visit my website to read to this lecture. Thank you. Thank you, one and all.